Welcome to Cold Steel, the Canadian Journal of Surgery podcast, with your hosts Amir Farouk and Chad Ball. The goal of the CJS podcast is threefold. The first is to highlight the best research currently being completed by Canadian surgeons. The second is to offer educational topics for both surgeons and trainees alike. And most importantly, the third goal is to inspire discussion, thoughts, creativity, and career development in all Canadian surgeons. We hope you enjoy it. Welcome to a special recording of Cold Steel. In an effort to deliver creative and innovative content, we're excited to bring you a mock oral examination. Not to worry, no resident was hurt during the creation of this podcast, but my co-host Amir Farouk was kind enough to act as a guinea pig and be the examinee. So thanks to Amir for his continued bravery and mental toughness. I'd like to invite you to listen to the next wonder of the world, an extravaganza so remarkable it'll leave you breathless. You'll laugh, you'll cry, but you won't forget. Our examiners today may not be household names quite yet, but they are destined for big things. In the left corner, wearing red today, and an undisclosed weight, is Caitlin the Assassin Cahill. Caitlin grew up in Montreal and completed her undergrad at McGill. She eventually went on to residency in Ottawa and is now enjoying her first year of a colorectal fellowship. This has given her ample opportunity to develop a planned attack towards our examinee today. In the right corner, wearing red as well, and weighing it as a chiseled and pharmacologically enhanced 222 pounds, is your second examiner, Dr. Greg the Hammer Knapp. The Hammer grew up on the mean streets of Grimsby, Ontario. He barely escaped, but eventually made it to McMaster for medical school and Dalhousie for surgical residency. He worked for a year and is now a star surgical oncology fellow. Greg has been plotting a rebuttal for Amir since their incident known as the pickle problem. As best said by Apollo Creed in the final scene of Rocky III, ding, ding.
Okay, so you have a 47-year-old male. He's previously healthy, and he presents to the emergency department with a 14-hour history of severe epigastric pain and vomiting. His temperature is 38.2, heart rate 140, blood pressure 97/68, and SATs are 96% on room air. In the emerge, he gets 2 liters of Ringer's lactate and some basic labs are drawn. His white count is 19. Hemoglobin 155, bilirubin is 34, ALT, AST are around 100, and lipase is 17,000. A CT scan shows a calcified gallstone in the gallbladder, a 4 millimeter common bile duct, moderate abdominal ascites, marked peripancreatic inflammation, and necrosis of the entire pancreatic body, which is 80% of the gland. How will you manage this patient and discuss the role for antibiotics?
So this is a 47-year-old male who's presenting with severe acute necrotizing pancreatitis of gallstone origin. This patient needs to be treated with supportive therapy, and this patient appears to be potentially at high risk of getting quite ill. So I would consider admitting this patient to the intensive care unit if I felt that the patient's trajectory was on a worsening course. Otherwise, I would continue with fluid resuscitation of this patient, as well as good pain control. I would attempt to establish nutritional access for this patient, either orally via NG or nasoduodenal or nasojejunal feeding. And finally, in terms of antibiotics, I would not start this patient on antibiotics unless they developed obvious air in the gland or had some other feature to suggest an infection, or if they continue to worsen in the intensive care unit, then I might reconsider antibiotics, but I would not give them antibiotics at this point.
Okay. So the patient is admitted to the general surgery ward. Despite significant IV fluid administration, 4 hours later, his heart rate is still 120. His urine output is 10 to 15 cc's an hour. His abdomen is progressively distended, and the patient is confused and agitated. He now requires 4 liters of oxygen by nasal prong and is desaturating to 88%. His temperature is 38.6. What is your management now?
So this patient is continuing to deteriorate on the general surgery ward, and he likely needs more intensive monitoring in the form of ICU care. And so I would consult my ICU colleagues for admission in the intensive care unit and monitor his urine output closely, and particularly monitor for abdominal compartment syndrome.
Okay. So the patient is transferred to the ICU. Within 2 hours of being there, he is intubated. A chest x-ray shows a left pleural effusion. His saturation improves on AC ventilation with a PEEP of 10 and FiO2 of 60%. How would you advise the ICU to manage his nutrition?
So these patients can be fed orally. I would ask the ICU to continue to feed this patient with NG feeds, and if he doesn't tolerate that, then ask them to get our radiology colleagues to put the tube further down, either into the duodenum or into the jejunum, and continue with enteral feeds in that form.
So his abdomen remains distended with no stool per rectum. His bladder pressure is 22 millimeters of mercury. Abdominal x-ray shows a distended stomach, distended small bowel. There's a small amount of air in the left colon. His peak respiratory pressures have not increased over the course of the day. Urine output remains poor at 10 cc's per hour. Discuss the diagnosis and management of abdominal compartment syndrome.
So the abdominal compartment syndrome is a constellation of findings that are manifestations of increased intra-abdominal pressure. These include renal failure and respiratory failure, as well as potentially intra-abdominal ischemia. So these would be manifested in the forms of an increase in creatinine, poor urine output, as well as increasing ventilatory pressures. Another potential marker of this is bladder pressures over 20. So certainly this patient has some features of abdominal compartment syndrome. However, I don't know what the creatinine is, and the respiratory pressures have also not increased over the course of the day. To manage abdominal compartment syndrome, I would consider first adjunctive therapy, such as paralyzing the patient. But ultimately, if the patient continued to have compartment syndrome, the ultimate management would be decompressive laparotomy.
Okay. So over the course of the next 7 days, the patient improves. He is awake, alert, and weaning off of the ventilator. NJ feeds are going well, and his labs are normalizing. On post-admission day 10, his heart rate jumps to 115, his temperature is 39.5, and his white blood cell count goes from 14 to 22. What would you like to do?
So given that there's a change in the patient's picture, I would repeat this patient's CT scan to see if there's been any change. After repeating a history and physical exam to see if there's any obvious sources for what looks like a septic picture. So, for example, an infected line or skin rash, I would repeat a CT scan.
So you get a CT abdomen and pelvis, and there's a walled-off fluid collection comprising the body of the pancreas posterior to the stomach. There's rim enhancement effect and a few small collections of air in the fluid collections. What is the diagnosis, and how will you manage this?
So I would so this is a peripancreatic fluid collection, or walled off necrosum. I would consult my HPB colleagues for their suggestions, as well as review the images with my interventional radiology colleagues. Given that he has a fever as well as collections of air, he might be a candidate for a drain. But certainly I would have my HPB colleagues look at this as well and get their suggestions prior to intervening, as it may affect further interventions down the road.
Okay, so what exactly do you want to do?
I would drain this fluid collection.
Okay, anything else?
I would also start this patient on antibiotics.
Okay, what kind?
I would use IV meropenem.
Okay. When would you recommend this patient undergo a cholecystectomy?
This patient could undergo a cholecystectomy once they were out of the once their necrotizing pancreatitis had completely settled down. So obviously I would wait for this patient to be out of the intensive care unit and be at home, and I'd probably wait 2 to 3 months prior to recommending a cholecystectomy, just to allow any ongoing inflammation from the patient's pancreatitis to settle down.
Okay, that's it. Good job.
Thank you. That was a good one.
So should I debrief?
Yeah, that'd be great.
Okay, perfect. So I think you did really well, like in terms of knowledge and content, no concerns at all. You answered everything pretty much perfectly. So I just made a few notes here. So in the beginning, it's really good. So I think one of your strengths is that you're good at sort of summarizing the situation and kind of like, and I think that's a form of you mentally making sense of the story and everything in your head. So I think that's really good. But at the same time, just be careful to not be too wordy, because you do lose some time. Like I didn't actually time this, but in the actual exam, the questions will be, 5 or 10 minute questions. And so you just don't want to lose time being a little too wordy. So like, for example, when we got to the CT scan, I just sort of like moved you along because I knew you said what you wanted to do, but then you started going down a little bit of a rabbit hole of discussion as to why. And I was like, yeah, I know. Okay, good. I just wanted you to say CT scan. But no, that was really good. I really don't have too much to say otherwise.
I hope Dr. Ball didn't have a seizure listening to me talk about this pancreatitis patient.
No, that was good, Amir. I agree with Caitlin. Your style was good. Your flow was good. You didn't use a lot of extra words. You were pretty directed. It's an interesting question, though. If you're an examinee and you feel that the content of the question is a little bit off, and that can happen. I mean, the content in that particular question, is a bit off. There's not, in terms of purely what you should do. There really is no scenario where you should intervene in that patient with percutaneous techniques or endoscopic techniques before 30 days. That patient's getting better. They don't need antibiotics. There's a whole bunch of nuance there that really will be limited to someone who does a lot of pancreatitis as a pancreas surgeon. And that doesn't necessarily mean the answers that they're looking for are going to be correct.
Yeah, so this is one of the things, Dr. Ball, like if you look at Sabistons or whatever, they'll talk about putting in a drain for someone who has air in a collection and fever. So I kind of knew that that's where this was going, but yeah, I know certainly looking at your, the work that you put out, that that's not something that I might do in real life.
I think the important point is not the individual question or the nature of what might be off about it. The important point is how you're going to address that mentally and then verbally in an exam question. And I think it is okay to say, traditional dogma would say do this and then sort of deliver it like you have. But if you're concerned, you can also say, but my experience on a high volume pancreatitis service, for example, would be this other alternative, a pathway or approach, which is reasonable as well. And I think just showing that sort of level of nuance, if it makes you feel better in answering the question, is okay, as long as Caitlin says, you're moving along quickly.
Yeah, and we had that sort of teaching as well when we were preparing, is especially for subjects where there might be a little bit of institutional variation in how patients are managed. It's very reasonable to say, at my institution, like, this is how this would be managed, or in my training, this is how I manage this patient, for topics that, there could be some difference in what the textbooks say to what is done in real life, or even across the country, because that's something that we found at the review course, was that different places manage things slightly different. So I think, for example, in Calgary, I think you guys do some operative debridement through the stomach. Is that right? Like through the back wall of the stomach. Whereas I've never seen that in my life. And, the traditional kind of teaching is don't operate on these patients. So there's obviously variation in how things are managed. So I think that's fine to at least acknowledge that.
Yeah. Okay. Perfect. Thanks, Caitlin. All right, Greg, I think you're up.
So, Amir, I am going to time you.
Okay,
so we try to make this, if you do get a bit long-winded, then I'll either move you along or you won't finish the station.
Okay.
Okay, so
all right.
Here we go. So you see a 52-year-old woman with a new mass in the right breast at the 12 o'clock position. She's got a BMI of 32, no past medical history to speak of, no relevant family history, and no significant breast health history. No skin changes on exam. There's no obvious asymmetry, perhaps a bit of a fullness. It's difficult to palpate this lesion. Again, although maybe there's a fullness at the 12 o'clock position. Your axillary exam is negative, and she is perimenopausal. She comes with a diagnostic mammogram. She's got a 3.3 by 3.5 centimeter spiculated mass with internal calcifications. No other lesions in the breast. There's one enlarged lymph node, 1.2 centimeters, with 4 millimeters of cortical thickening that is suspicious. She is reported as a BI-RADS5. Core biopsy comes back in the breast as invasive ductal, grade 2, ER positive, PR negative, HER2 negative. Axillary node is also positive for invasive ductal carcinoma. What is the next step in her management?
So this is a 52-year-old female with a new breast cancer and a positive axillary node. This patient should be sent to medical oncology for consideration of neoadjuvant chemotherapy, followed by surgical resection.
Is there anything else that you would do at this time?
I would also conduct a staging workup to including a CT chest, abdomen, pelvis, to ensure there was no other metastatic disease, plus or minus an MRI if she had any neurological symptoms.
Any other staging investigations?
I would do a CBC lights and creatinine, as well as an LDH and a bone scan.
So the patient has a CT chest, abdomen, pelvis, no evidence of metastatic disease. CBC is normal. LFTs, ELK phos are normal. Bone scan, no evidence of metastatic disease. So what would you recommend at this point?
So I would recommend that this patient be sent to medical oncology for consideration of neoadjuvant chemotherapy because of the positive axillary node.
So patient has a clip placed in the involved node. She receives 6 cycles of FEC-D. Repeat diagnostic mammogram and ultrasound demonstrates the primary breast lesion has responded, 3 centimeters by 2.8, so it's still evident. Clipped axillary node is measured at 0.8 centimeters with equivocal cortical thickening. Your clinical exam is unchanged. Patient wishes to have breast-conserving surgery. What will you offer this patient?
So given that this patient would like to have breast-conserving therapy, that would be appropriate in this scenario. I would offer the patient a wire localized lumpectomy and sentinel lymph node biopsy with blue dye as well as lymphoscintigraphy.
The patient has a lumpectomy plus sentinel lymph node biopsy with removal of the clip node. The final pathology is a T2N1 adenocarcinoma grade 2, negative margins, LVI present. 2 of 3 nodes are positive with 3 millimeters of disease, no extranodal extension. What would you offer, or would you offer this patient any additional treatment? And then what adjuvant treatment would you expect this patient to be offered?
So, although this patient appears to only have T2N1, this is in the context of the patient having had neoadjuvant chemotherapy. Given that she has not had a complete pathologic response, I would offer the patient a axillary lymph node dissection. The alternative would be to discuss this at a multidisciplinary, I would discuss this at a multidisciplinary tumor board meeting for any inputs from our radiation oncology colleagues as to whether axillary node dissection versus axillary radiation would be best for this patient. But I would offer this patient axillary lymph node dissection. This patient is ER positive, PR negative, and HER2 negative. So I expect that this patient would potentially be offered further adjuvant chemotherapy, but no additional hormonal therapy.
Would she receive any other adjuvant treatment to the breast?
Yes, she would receive radiation as well.
Would this patient be a candidate for anti-hormonal therapy?
She is ER positive but PR negative. She might be a candidate for hormonal therapy.
Okay. That's it.
Whoa. Oh boy. All right. Let me have it.
So again, I think you're warming up a little bit. So that I thought that your flow was better. You're quicker, a little bit less, a bit more to the point. In terms of going through that station, you certainly hit all the high points. I think this would. There were no red flags. So you moved through it quickly. You hit all the key decision points. I think just remember, on a couple times I did have to kind of rephrase or ask you another question, and that's okay. I think in my experience, they would do that. That may be a little bit. As standardized as it is, it may still be a little bit examiner dependent. The only thing I would kind of comment on from a content point of view is 2 things. One, I think that your answer about how the axilla would be managed was perfect. I still think that on a oral exam, the standard of care for this patient would still be axillary lymph node dissection, but I think it's super appropriate to say exactly what you did, which was, this would be discussed in a multidisciplinary tumor board. The axilla needs some additional treatment, whether or not it's axe dissection or, targeted axillary radiotherapy, is kind of like the absolute perfect answer. And so I thought that was done very, very well. In terms of adjuvant therapy, so she's already received her chemotherapy, her full dose of chemotherapy up front. So her adjuvant therapy, and this was not a make or break question, would be obviously whole breast radiation. She likely would receive axillary radiotherapy, and then she would receive anti-hormonal therapy probably as tamoxifen transitioning to an AI because she's perimenopausal. But that's kind of nuanced stuff. But I think that certainly wasn't the like surgical red flag decision making point in this station. So
all right. So a 38-year-old RCMP officer was shot in the abdomen at close range while doing a routine traffic stop. You're on call and are notified that the patient is 5 minutes from the hospital, tachycardic and hypotensive. What will you do before the patient arrives in the emergency department?
So I would ask the emergency department to put out a level 1 call out. This would mobilize the emergency department team, including nurses, respiratory therapist, another emerge physician, as well as prepare the as well as I would prepare the trauma bay, having two chest tube trays available, and I would assign roles prior to the patient arriving in the emergency department. I would also alert the blood bank that we might need blood.
Okay. So the patient arrives. He's GCS 15, talking and moaning in pain. His heart rate is 120, blood pressure 90/45. There is a 2 centimeter hole in the epigastrium and a 1 centimeter hole in the posterior right flank. There is bleeding and a bullet hole at the left elbow. What is your initial management?
So I would I would do my primary survey. So the airway is patent. I would put the patient on oxygen. I would put the patient on monitors. I would start the patient on. I would call for a massive transfusion protocol. I would establish good IV access. I would inspect the patient from head to toe to ensure that there were no other bullet wounds or injuries besides the ones that I've seen. And I would obtain a chest X-ray and a pelvic X-ray as well. Yeah, that's what I would do, and as well as I would do a abdominal fast and pericardial fast.
Okay. So the chest X-ray is normal. The abdominal X-ray and pelvic X-ray show that there is free air in the abdomen. No metal fragments are seen. The vital signs are the same. Heart rate is 120, blood pressure 90/45. What is your next step in management?
So this patient needs to go to the operating room. So I would call up to the OR and book this as a E0 trauma laparotomy. I would and I would mobilize the team. I would also ask for the patient to be started on some or be given tranexamic acid.
Okay. So the patient is brought to the OR for an emergency trauma laparotomy. You identify a transverse colon injury with feculent contamination, a transverse colon mesenteric injury with profuse bleeding, distal pancreatic injury. The patient's heart rate is 110, blood pressure is 90/50 after 2 units of packed red blood cells. In the OR now, how will you manage this case?
And otherwise, do we have any information about the patient's physiology, such as from their ABG, as well as if they're on any pressors or any other? No.
No extra information.
Okay. So this patient is sick, but stable. I would control the bleeding first by quickly resecting that portion of the transverse colon and stapling off the ends. I would inspect the pancreatic injury. Given that this patient is stable, complete the distal pancreatectomy, and then ask the anesthetist if the patient remains stable as to whether I can complete my reconstruction in terms of the colon.
So you perform a segmental transverse colectomy. This is left in discontinuity. A drain is left adjacent to the pancreatic injury. A temporary abdominal closure is placed, and the patient is brought to the ICU. The patient is stabilized in the ICU and brought back to the OR 24 hours later. At this time, the colon appears healthy. There is no further bleeding and no other injuries are identified. The distal pancreas appears contused. How will you manage this case?
I would complete an extended right hemicolectomy with a primary anastomosis to complete my resection for the colon injury. I would examine the pancreas closely to see if there is any involvement of the pancreatic duct. If there does not appear to be any evidence of a pancreatic duct disruption, I would leave wide drainage and leave the pancreas as is. I would also ask a HBB colleague to potentially ultrasound the pancreatic duct to ensure that there's no pancreatic duct.
So the patient stabilizes over the next few days. His elbow is pinned 3 to 4 days later by ortho. He develops a pancreatic leak identified by the drain fluid. His bowels resume their function. He's stable and transferred to the ward on post-op day 5. On post-op day 7, the patient suddenly worsens clinically and appears septic with diffuse peritonitis. How will you manage the patient?
So this patient needs to be started on antibiotics and resuscitated and taken back to the operating room for a relook laparotomy, as I'm concerned for an anastomotic leak.
Okay. Get a CT scan that shows free air and an infected hematoma in the pancreatic bed. What do you think is happening and what is your management plan?
So, as I said, I'm worried that this patient has either a missed enteric injury or an anastomotic leak. I would start this patient on antibiotics and resuscitate them with fluid, and then take them back to the operating room for a washout and management and definitive management of any injuries.
Okay, so you bring the patient back to the operating room and you find an anastomotic leak. There is an infected hematoma in the pancreatic bed, but no acute bleeding. How will you manage the anastomotic leak?
This patient will get an end ileostomy and wide drainage of the area of the pancreatic bed if there isn't already drains there. Otherwise, I would not explore the hematoma or disrupt that.
Okay, and what will you do with the colonic stump?
The colonic stump I would mature as a mucus fistula.
So the patient recovers well, his bowels recover, and he returns to the ward. On post-op day 7 from his take back, so post-op day 14 from the initial trauma, the patient crashes on the ward and a code is called. He is brought to the ICU after ROSC. Heart rate is 150, blood pressure 75/30. The abdomen is tense. What is your management?
So this patient is hypotensive. I would obtain stat labs in form of an ABG, and resuscitate the patient with fluids. If the patient could tolerate it, I would obtain a CT scan here. But obviously, if the patient was continued to deteriorate, I would take the patient back to the operating room. But I would obtain the CBC and CT if at all possible.
Okay. You bring the patient back to the operating room. His abdomen is filled with fresh blood. This massive bleeding appears to be coming from behind the pancreas. The patient is very unstable. What is the likely source of this bleed, and what is your management?
So I would be concerned that this represents an erosion of the pancreatic leak into likely the splenic artery or one of the post pancreatic blood vessels, but most likely the splenic artery. I would obtain exposure to the splenic artery proximally and distally, which would likely involve doing a distal pancreatectomy, and tie off the splenic artery. Oh boy.
So trauma ones are definitely like a little bit harder just mentally, at least for me, because I feel like a trauma in real life is really fast paced. And so then on the exam, like you have that kind of like sympathetic response in your body as if it's a real trauma, but it's still just an oral exam. So I think so the beginning was really great, like preparing the emergency department, you hit all of the points there. Once the patient arrives and they're asking your initial management, so for the exam, you just want to have your trauma spiel, like you just have it like ready to roll off your tongue. I'll approach this patient in standard ATLS fashion with my primary survey, A, B, C, D, E. I'll have blah, blah, blah. You just want to list it all off. It's just a spiel that should fall out of your mouth. So yours was just a little bit disorganized, and wasn't rehearsed. So that's just a matter of practice. Otherwise, I think your management was good. When you were in the OR for the first time, I think you were a little bit thrown off about like how, like you did all the right things. But again, in a trauma situation where there's multiple injuries, like your first thing is always manage the bleeding. You mentioned communication with anesthesia, which is great. And then just take each injury one at a time. Obviously in the real life situation, you're not able to necessarily be super methodical, like 1, 2, 3, 4. There's multiple hands in the belly, etc. But in the exam situation, you can't do everything all at once. So just take each injury one at a time. So for the bleeding, I'll do this. For the colonic injury, I'll do this. So these are just like ways to be a little less stressed in the face of the trauma question. But yeah, otherwise I thought like your management was really good. Again, if the next slide isn't exactly what you would have done, that's totally fine. It happens all the time. You just roll with it. And yeah, no specific concerns. I thought that was good.
Yeah, I was a bit thrown off because to me, like the pH and the like not just the heart rate and the blood pressure would have dictated what I did. So I was in two minds as to what I would do. Like I would probably do the resection, stop the bleeding, and then recoup and see where I was at. Because if the patient was stable, I probably would just do everything, all the definitive stuff right off the bat. But certainly, I take your point about being systematic in just describing it.
And you might not always have all that information, right? Like there's a lot of times where the slide is not going to have the information and the examiner is not going to provide it. Like if it's not on the slide, it's not there.
Yeah, I think that's a good point, Amir. I can, knowing you well, I'm sitting here watching you answer this question. What you're thinking, I'm sure, is, well, we don't treat gunshots based on ATLS dogma, right? We treat them the opposite. C comes before A, for example. And then, as you pointed out, your progression and your cadence and your pathway in that case depends entirely on that first and probably second ABG. But, Caitlin's point's important too. The examiners, that might not be their area. The person that wrote the question may not understand that nuance and may take you in a totally different direction. So you have to be malleable like you were in terms of putting you in a different place. And I suspect that this question was probably written to show actually poor management, because there was 2 obviously subsequent complications that peaked to the level you had to take them back to the operating theater. I mean, that's an absolute disaster of a case and of management up front, right? It's very poor. So they probably want you to talk about complications and reacting to them and recognizing when you did great.
Okay. Thank you guys again for the feedback.
This is a 52-year-old male with a referral from his family physician concerning a new perianal lesion, non-healing times 6 months. On exam, the lesion is as shown. What is your differential diagnosis?
Okay, so I would be worried about benign and malignant causes of this lesion. Certainly, I'd be concerned here about this patient having a squamous cell carcinoma. This patient could have condyloma acuminatum. This patient could have a Buschke-Lowenstein tumor. Benign causes, I suppose, could be skin tags, inflammatory changes from chronic Crohn's, proctitis. That would be my main differential. And I suppose a long-standing infection as well in terms of perineal abscess could theoretically look like this.
Okay. Past medical history, patient is otherwise healthy, no comorbidities. Social history, he works as an accountant, lives with his male partner, 15-pack year smoking history, occasional alcohol use, no medications, no known drug allergies. On exam, lesion is about 4 centimeters in diameter, ulcerated, firm. There's no obvious involvement into the anal canal. There's also, though, a firm, palpable lymph node in the right groin. The remainder of the exam is unremarkable. What is the next step?
I would perform an examination under anesthesia for this patient to get biopsies of this lesion, as well as perform a full anoscopy. I would also obtain a FNA of the palpable lymph node in the right groin.
So the biopsy of the node in the perianal lesion comes back as a poorly differentiated squamous cell carcinoma. What further investigations would you order?
So I would stage this patient. So I would obtain a CT chest, abdomen, and pelvis looking for metastatic disease. I would also obtain an MRI of the pelvis to characterize the local involvement of this lesion. I would obtain baseline blood work such as a CBC lights, creatinine, and liver enzymes.
Any additional investigations?
No further investigations.
So you order a CT chest abdo-pelvis. There's no evidence of distant metastases, but they do see the suspicious node in the right groin, as well as a suspicious node in the mesorectum. MRI of the pelvis lesion involves the external sphincter, but no other adjacent organs. The PET scan, there is FDG avidity at the primary and in the right inguinal node, and the mesorectal node is mildly avid. Patient is also HIV negative. What is the T stage of this squamous cell carcinoma?
Just remind me how big it was.
4 centimeters.
Okay. Yeah. This is a T4 lesion.
Okay. So what are the components of the NIGRO protocol, or non-operative management of anal canal squamous cell carcinoma?
So NIGRO protocol would involve chemotherapy and radiation. The chemotherapy is mitomycin C and 5-FU, and as well as radiation. The likelihood of a complete clinical response in this scenario is approximately 70 to 80%.
Great. So the patient receives a single dose mitomycin followed by a 4-day infusion of 5-FU, and then receives concurrent with that 50 grays over 25 fractions. This includes the mesorectum in the inguinal and iliac nodes. When do you want to see the patient back for follow-up?
I'd like to see the patient back for follow-up in 6 to 8 weeks after the completion of their completion of their treatment.
Okay. So you see the patient at 4 and 8 weeks after completion of treatment. Regression is quite obvious. At 12 weeks, however, there appears to be a response. There's still a response, but a residual lesion is obvious on exam. What is your next step?
I would continue to follow this patient for up to 6 months with monthly visits and physical examinations to see and document that the lesion continues to regress.
Excellent. You see the patient back every 4 weeks with ongoing response. At 6 months, he's had a complete clinical response. The lymph node exam is also normal. Repeat staging confirms that. The PET shows no FDG uptake at the previously added sites. What is the next step in management?
So I would see this patient every 6 months for the next 2 years. Followed by every year until we get out to 5 years with a full physical examination as well as perianal exam and rigid proctoscopy. I would also get a colonoscopy.
We follow the patient with exam and DRE every 3 to 6 months, out for 5 years, as well as regular endoscopy and CT chest abdomen pelvis. At 15 months, you notice a new palpable right inguinal lymph node. Your perianal and anal canal exam is free of disease. What is the management?
I would obtain an FNA of this right inguinal lymph node as well as a PET scan.
So the biopsy shows poorly differentiated squamous cell. Additional investigations, as you mentioned, CT chest abdo-pelvis, no additional disease. PET scan is congruent. And what is the next step in your management?
I would discuss this patient at a multidisciplinary tumor board meeting and consider this patient for a lymph node dissection on the right side.
And what are the key components of the consent process for this procedure?
So I would explain the risks of the procedure. So the key steps is explaining the procedure itself as well as the alternatives, which is in this case would likely be to just watch it. For the procedure, I would explain that this risk, there are the usual risks with any surgery, such as bleeding, infection, general anesthetic complications. Specifically, here there would be a risk for lymph leak and infection.
Okay.
And nerve injury, I guess.
Okay, so that was a bit longer. Sorry that didn't behave for us. Even at the end there, you got a bit of a freebie. So just in terms of feedback, I think you definitely hit again. There were no red flags, like from a surgical management, from a progression through the station, from a management point of view. Two quick things. One, it is the lesion was 4 centimeters, so it would be a T2. T4 would be invading adjacent structures, so bladder, bowel, involvement of the external sphincter doesn't count. But that was kind of like a bonus point. Otherwise, really, the only thing would be in the workup for anything greater than 2 centimeters. Mention getting a PET scan because they're super PET avid. Would be the only kind of additional piece to the workup. And then again, a bonus point was just risk factors for anal canal, squame, HIV, right? So I kind of gave you, some risk factors. And so just make sure that for everyone, you're mentioning that HIV status, because if you optimize their HIV status, they have improved outcomes. And so that was it, though, in terms of feedback. I thought your examinship, was spot on, right? I think as you're going through these questions today, you are getting tighter and tighter, and I think that for me, anyways, was something I struggled with during the exam. Is that when I started, I had to really practice on not being overly wordy. I think that's kind of like my tendency. And then you just get yourself, A, you waste time, and then B, you're going to say something that, isn't relevant or potentially throws you off or the examiner off. So just, you were already doing that, stay tight, stay kind of concise, and just get through the station. And I think that just came with practice. And that is less about kind of how, it's less about your knowledge base and how you are, or how your decision, it's less about your decision-making process and more, unfortunately, just about examinship, which is, probably not the intended outcome of the oral exam, but, ends up becoming a big part of performing well on it.
Absolutely. I did want to ask one thing about the PET scan, because that wasn't something that I had come across in studying. Is that something in the NCCN in terms of if you have a big over 4 centimeters, is that part of NCCN to actually get a PET scan?
Yeah. Okay. Yeah. So and again, you're that was not the plus or minus PET scan was definitely not going to be like a fail, not fail, right? Like, because there's going to be some institutional variability, but for sure, given how PET avid it is, and the fact that you felt kind of regional disease on your exam, NCCN would, and I think, that would still be quite standard. Yeah.
Thanks again, Caitlin and Greg, for coming on and doing this. I think people are going to find it really helpful and beneficial. You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.